like is multinucleate. And I put cardiac and skeletal because on our notes it says 1 or 2 nuclei for cardiac, but it said it was wrong. Yeah, like even that. Okay. Just skeletal. Okay, thank you.
Good afternoon. Welcome to our very last technically real class. Can you believe we made it this far? Like, we're so close to the end. I appreciate all of you that came today. I know that especially this week, we are like mentally checked out, right? So I appreciate you being here. A few notes for you as we're answering the square cap question here. Note number 1. I have just completely assembled and got exam number 5 ready for us. Here's some good news. Exam number 5 only has 40 questions. It's a lot shorter than some of them. So that's good news. Yay, yeah, we're excited about that. Okay, so that's our good news. Remember that exam number 5 is going to have chapter 9, muscle tissue, and it's going to have the stuff from today, joints. Here's the deal with the stuff from today, though. It's not going to be covered quite as much. There just aren't as many questions that I have to ask about joints compared to muscle tissue. So that's code for me saying, really, really know your chapter 9 stuff really well. Do as much as you possibly can between now and whenever you take the exam number 5 on these joints. I'm going to try to give you some pro tips as we're working through joints today to help you know, here's the stuff that's really important, make sure we know this. But again, this exam is going to be shorter than all of the other ones we've taken, which means that there's a pretty good chance that if you study well, you could get a pretty good score on this one. Let's use exam number 5 to help boost our exam scores as we get ready for the final. As we're talking about the final, remember that we don't technically have class on Wednesday, but because the classroom is available, I will have a live class session with you all from 2:30 to 3:50 at our normal time. What I'm going to do is based on what you all tell me here in my square cap question, I'm going to pull together a series of activities for us to do. So I'm going to figure out, hey, we really want to talk about vision. Okay, here's a quick blurb about vision. Here's a question. We really want to talk about skin. I don't know, whatever it is that we decide that we want to talk about. So I'll give us little quick content reviews, and then we'll do some practice questions to go with it. So that to say, if you are at all available and can be on campus here Wednesday, I would love for you to be here. It's going to be really helpful for you to get you ready for the final exam. Final exam, by the way, is going to be open next Tuesday at 12:01 a.m. all the way through next Wednesday at 11:59 p.m. So you have that 48-hour window to take that exam. If you would like to take the exam in person and not have to worry about your webcam being there watching you, I will be giving our exam here in our classroom at the time they assign for us. So the time they assign for us to take the final exam is Monday afternoon at 2 o'clock. So I guess maybe actually the exam will open up Monday at 2. So if you come to take the exam with me, I will record. I'm going to have a list. You'll show me your ID. When you come to take the exam with me, you are going to sit here in the classroom. Your built-in webcam is totally sufficient. And when you finish that, you are done with the class. If you would prefer to take it at home, when your normal testing space, whenever in that window, that's totally fine. But please know that you do have to use an external webcam. Final exam is a non-negotiable, like we can't have tech issues. So if your webcam has been giving you trouble throughout the semester, this is the time where we probably need to go to Walmart and just buy the cheapest webcam they've got. We've got to have a webcam. Or if your roommate has a webcam, say, hey, I need it from this time to this time. Phones have been notoriously unreliable here at the end of the semester. So please, if you're not going to take the exam with me next Monday, please use an actual webcam to get you ready for that exam. One other note for you. I've said this before, but I want to make sure to say it again. If you have any assignments in the gradebook, that's homework, that's quizzes. If there is anything that you have that says it's missing right now and has a 0, you can still go in and do that. So at any point between now and the end of the semester, any 0s you've got, go in and do those assignments. Not only will it be good practice, it'll raise your grade from where it's at. So keep those things in mind. Let's see what we want to talk about on Wednesday. Okay, so I see a note about muscles. My question, maybe you all can help me out. When we talk about muscles, are we talking specific muscles or like muscle physiology? Physiology or specific? Okay, I've got a mix of both. So I'll cover a little bit of both. You know what I'll do with you too regarding specific muscles is I'll make sure to give you some good rules to just memorize muscles in a group. Let's see, we've got kind of divided up. So I'm seeing some nervous stuff. Yeah, so nervous chapters in there. Okay, so I'm gonna kind of, I'll go through this when I get back to my office. It looks like we definitely want to talk about some muscle stuff. The good news is you're studying that muscle stuff for the exam. So hopefully by Wednesday we'll feel a little bit better about it. But then I'll also go through and figure out, we'll probably do some nervous tissue stuff, some special senses stuff, and I'll see what else we've got. So I will make it worth your while to be here on Wednesday. Please plan to come see me. Very last chapter. And I think we're going to get through all of it today. If not, we'll definitely make a video for you. All chapter 8 is about is the joints in our body. So when we talk about joints in the body, all we mean is a place where two bones meet. So sometimes bones are going to meet in a place that moves a lot. You can see these highlighted joints here where there's a whole lot of movement. But we're also going to have some types of joints, some places where bones meet where there's not a lot of movement. So it's just a location where two things come together. When we talk about what joints do for us, obviously they're a connection point, but they're also what allows us to do movements. This is how you do all of the movements that you're able to do. On the opposite side of that, as we'll talk about here in a moment though, some of my joints actually block movement. They're a way for two bones to come together with 0 movement. So when we're classifying our joints, we can classify them 2 ways. We can either classify them based on how the bones come together. So is there cartilage there? Is there connective tissue? Is there fluid? Or we can classify them based on how much they move. So the way we're going to go through and talk about joints today, this is how I want you to be thinking about every joint we talk about. How did I bring the bones together? And how much do they move? If I can keep those big picture things in mind, I'm going to be good for our exam. So let's start with the words I'm going to use when I'm talking about how much things move at a joint. The first word I'm going to use is called synarthrosis. And a synarthrosis is an immovable joint. So think about a place where two bones come together. For example, the bones of the skull. There is no movement, or there shouldn't be movement, between the bones of your skull. They should be stable. This beginning part right here, by the way, sin means without. So without movement, an immovable joint, that's a synarthrosis. Some of the joints in the body are called amphiarthroses, and an amphiarthrosis is slightly movable. And what I'll say with these amphiarthroses, you probably wouldn't even necessarily think about these joints as moving, but it's kind of like they just do a little bit of wiggling. So the best examples of amphiarthroses, it's going to be between the two halves of your hip. This is called the pubic symphysis. That's a great example of an amphiarthrosis. Also between my vertebrae in the spine, where there's a little bit of movement, but not the kinds of movement we usually think of. When we're usually thinking of movement, we're thinking of diarthroses. So diarthroses are freely movable joints. These are the joints that help you take notes. These are the joints that help you stand up and sit back down. So when you think of joints, you're usually thinking of a diarthrosis, something that can freely move. But as we start looking at these other kinds of joints, these other ways that bones come together, sometimes they only move a little bit, they wiggle maybe. Sometimes they don't move at all. Those are my functional classifications. As I introduce you to specific types of joints now, we're going to talk about them with their structural classifications. So my first group of joints are what I call fibrous joints. Fibrous joints are two bones come together, and I use collagen fibers to connect them. So once you've written the word collagen, I want you to underline, highlight, star, collagen fibers. A fibrous joint where two bones come together using collagen fibers. When we talk about joints that use collagen to come together, most of them are going to be synarthroses. When I use the word synarthrosis, what does that mean about how much movement we do? Yeah, no movement, right? Synarthroses, no movement. Most of my fibrous joints are no movement. But I do have an example that is an amphiarthrosis. And remember that amphiarthrosis means a little bit of movement. I do a little bit of wiggling, but that's it. So here's a wink, wink, nudge, nudge study tip. Any kind of joint that you're studying, that you learn is a fibrous joint that's coming together with collagen fibers, if I ask you for its functional classification, if I ask you for its movement word, it's always, always going to be either no movement, synarthrosis, or a little bit of movement, amphiarthrosis. Always 100% of the time. So let's talk about our specific types of fibrous joints. And here's what I'm going to tell you. I'm less interested that you learn these specific names of each of these fibrous joints. I'm more interested in you knowing where they are. Because on the exam, I might ask you, hey, the sutures between your skull bone. If I know where sutures are, that they're in the skull, I'm good. So when I talk about my first kind of joint where I bring bones together with collagen, these are called sutures. And sutures are the immovable joints between the bones of my skull. Now, I'll mention with these sutures, if you notice in my picture here, they show you some different ways that the bones can come together. A lot of times with sutures, think of it kind of like if I had bone, with each of my fingers was bone, and I brought them together like this, and then I used collagen to seal them. This is why fibrous joints, suture joints, are immovable, because the bone is overlapping and the collagen holds it in place. So first kind of joint that is a fibrous joint, my sutures. Second kind of joint has this really weird name. It's called a gomphosis. What I want you to know about a gomphosis is this is what holds your teeth in place. So gomphosis, this weird word, it's just the name of the place where your teeth connect to your jaw bones. We have a special name for the collagen fibers that connect your teeth to the jawbone. It's a thing called the periodontal ligament. And hey, let's underline, highlight, star ligament, because ligaments are always made out of collagen. So if you remember that we attach our teeth to the jaw bones using ligaments, you'll know that this is a fibrous joint. If your teeth are healthy, our tooth sockets should be synarthrotic, That means your teeth should or should not be moving. Should not. Yeah, so gum foci, another example, should not be moving, no movement. This is what we find holding your teeth in place. My last example of a fibrous joint is what I call a syndesmosis. And when I talk about a syndesmosis, this is a kind of joint where we see a big group of collagen fibers. So for example, down here, connecting together my bones. I see syndesmoses connecting together the tibia and the fibula. That's what we see here. I also see them connecting together the radius and the ulna. When you think about the tibia and the fibula, the radius and the ulna, these are in parts of your body where we do some movements. Remember, this word amphiarthrosis means a little bit of wiggling. So if you think about how much your arms move, how much your legs move, it's good that even though we hold together these bones really stable, it's good that they have a little bit of wiggle room in case we need to rotate our hand, in case we need to rotate our foot. So 3 kinds of joints that come together with collagen: sutures, gum foci, syndesmoses. Most of these not moving, sutures and gum foci. Little bit of movement when I have big flat collagen fibers, like between these 2 sets of bones. The next way that I classify my joints is cartilaginous joints. And it should be no surprise that a cartilaginous joint, we bring our bones together with cartilage. And when we're thinking about these cartilaginous joints, again, we're going to be in the same boat, where we either have amphiarthroses, we do some wiggling, or we're synarthroses, no movement. The only difference between my 2 types of cartilaginous joints is the kind of cartilage they use to build the joint. So here's a wink, wink, nudge, nudge. We want to make sure we know which kind of cartilage is used to build these 2 kinds of joints. That's a question you can definitely expect to see. So let's start with our synchondrosis. When we talk about a synchondrosis, I want you to underline, highlight, star, hyaline cartilage. Hyaline cartilage. A synchondrosis forms when 2 parts of a bone are connected with hyaline cartilage. So the main place that we talked about hyaline cartilage in bones was the epiphyseal plate, the growth plate. So for as long as you have hyaline cartilage, as long as the bone is growing, we would say that we have synchondroses in that bone. We have these joints that are not moving, we hope, right? We don't want to separate those parts of the bone. So hyaline cartilage in the epiphyseal plate. The other place that I see this hyaline cartilage, these synchondroses, is connecting your first rib over to the sternum. So at the very top, we have this other immovable joint that's going to help to protect all of the things coming down from your throat. So synchondroses, hyaline cartilage. When we're talking about symphyses, let's underline, highlight, star, fibrocartilaginous. Or you can write the word fibrocartilage. Symphyses are made with fibrocartilage, my tough kind of cartilage. There are 2 places in the body where we have symphyses. Place number 1 are those intervertebral discs, the cartilage between each of your vertebrae. We want to have a cushion there. Fibrocartilage is my cushion. The other place that we see a symphysis is the place that's literally called a symphysis, the pubic symphysis. Again, fibrocartilage that holds the 2 halves of the pelvis together. Notice that symphyses are amphiarthroses. If I have the really tough kind of cartilage, I get a little bit of wiggle room with that. When I have my hyaline cartilage over here, no wiggle, no movement. So, cartilaginous joints. Either we use hyaline cartilage That's a synchondrosis. Or we use fibrocartilage. That's a symphysis. Make sure we know what kind of cartilage and have a general idea of where these things are. Growth plate versus the two halves of the pelvis, or between my vertebrae. That brings us to our last kind of joint. And this is the kind of joint, again, when you think about joints, this is what you're thinking of. You're thinking of what's called a synovial joint. And what makes synovial joints special or important is the fact that they have these fluid-filled spaces in between the bones. If I have fluid between my two bones, those bones aren't touching, they're not tightly connected, which means that they're going to be able to move. So these joints are examples of diarthroses. When we talk about a diarthrosis, how much movement do these ones have? A lot, right? These are my freely moving joints. So from this point on, when I start talking to you about specific synovial joints, 100% of the time, we would say that a synovial joint is a diarthrosis. 100% of the time, they are freely moving. Different kinds of movements, but freely moving. And again, it's because they have this fluid-filled capsule. It's because there's fluid in between the bones that they can move past each other. When we look inside synovial joints, there are some specific structures that you need to be familiar with. So first structure is a layer of cartilage that I find on the top of each of my bones. So notice at the end of this bone and at the end of this bone, I have this cartilage plate. It's not holding them together this time, but it's acting kind of like a smoothing surface between the bones. We'll talk about later in our class, if I lose this cartilage, then I start to develop painful movements because this helps it to move smoothly. So inside my joint cavity, my fluid-filled space, I've got these bones covered in cartilage. The fluid, by the way, since it's in a synovial joint, is called synovial fluid. We're constantly making it with the cells that live inside our synovial joint. They're constantly remaking it. So that synovial fluid, its job is to take care of my cartilage cells that live in the cartilage and also to help with that smooth movement. On the very outside of my synovial joints, we have what's called the articular capsule. And the articular capsule is what helps keep these two bones that aren't technically connected to each other, keeps them close together. So if somebody is double jointed, what that actually means, not that they have an extra joint, but probably their articular capsule is a little bit looser than the capsule in somebody else. Their bones can move in ways that everyone else's bones cannot. So holding those bones together, and then on the inside of it, we have this synovial layer where that fluid comes from. The last thing that we have is what we call reinforcing ligaments, especially in major joints like your shoulder and in your hip joint. Because these things are freely moving around, we need to have something to keep them on track, to keep them in the right place. Now that I've introduced you to our functional words, our arthroses, and our structural words, we're going to try a couple of square cap questions. So let me pull that up for us. I've got 1, 2, 3, 4. Oh man, I went nuts. Let's see if we do all these together. All right, I got lots of questions, so I'll give us plenty of time. There are 6 questions in there right now. 1 quick wink, wink, nudge, nudge. This question right here, number 7, asks you for a functional classification of the joint between the vertebrae. Check this out. Joint between the vertebrae, structural classification for number 6. So I point that out. Read these questions carefully so you're not giving me the wrong kind of classification for these joints. I'll stop talking, give you a chance to work. Sorry, I missed one last blank for you. I apologize. The last thing to mention is that inside these joints, we do also have nerves and blood vessels. And those nerves and blood vessels help you to know when you've overextended the joint, so if we have pain problems, and also helps to provide nourishment and positioning. Sorry about that. I'll give us about one more minute to wrap it up. right, last call on my first question. We're going to start reviewing in 5, 4, 3, 2, 1. The first question I asked you was to remind you about how when we build joints in the body, there's more than one kind of cartilage that I can use to bring the bones together. So my first question asked you about what we call the articular cartilage, so the cartilage at the ends of your bones, and also the cartilage that I use to connect the ribs to the sternum. So we talked specifically about rib 1 going to the sternum, and we mentioned that articular cartilage. These are two locations that we would find hyaline cartilage. So hyaline cartilage found lining the bones of my joints and attaching the sternum to the ribs. Next, I asked you about another kind of joints that also uses cartilage, but this time the cartilage is not hyaline cartilage. This time the cartilage is fibrocartilage. Because remember, my intervertebral discs need to be really tough, so I've got that fibrous cartilage. My pubic symphysis, the halves of my pelvis, need to be held together well, fibrocartilage. If we know those things, by the way, the two kinds of cartilage, remember that that's what made a symphysis different from a synchondrosis. So if you see a question asking about one of these places, if you can remember which kind of cartilage is there, you can get to the name of that kind of joint. Then I started to ask you some of our classification questions. So the first question that I asked you, and I underlined it and put it in bold, I wanted a structural classification. When we talk about structural classifications, remember that those are my fibrous, cartilaginous, or synovial, which, don't worry, we're going to break up into way more pieces in a moment. Structural classification, here's my options. When we're talking about attaching the teeth to the jaw, my special name for this kind of joint is a gomphosis. Now, check this out. If I'm taking the exam and I don't remember for sure with all these crazy anatomy words which one it is, if I can start by getting which of my categories we're in, is this a fibrous joint, is this a cartilaginous joint, or is this a synovial joint? If I can get that off the top, that helps me to at least eliminate some other answer options. So when you're studying, first, make sure we know which of those big three it is, and then try to fill in the more specific information. But for sure, know the big three. So that's my structural classification of the sockets, the gomphoses. Then I asked you for a functional classification. When we talk about the functional classification, now we've got these arthrosis words, these movement words. And remember, if our teeth are healthy, they should not be moving. So synarthroses, an example of the kind of movement at a fibrous gomphosis joint. Then I asked you for my structural classification of the joints between my vertebrae. Remember where I have those intervertebral discs. And we already told ourselves that the intervertebral discs are made out of fibrocartilage. And fibrocartilage is what I find in these symphysis joints. Now, if instead of asking you about the intervertebral joints, if maybe instead I'd asked about the epiphyseal plate, that would be something that would be my other kind of cartilaginous joint, the synchondrosis, because again, it has hyaline cartilage instead of fibrocartilage. So there's my structural classification. And when we're talking about our intervertebral joints, we want a little bit of wiggle room. These are amphiarthroses. Friendly reminder that after class, you can always go back and look at these questions, and I actually often put feedback related to different answers in there. These kinds of questions, great practice for the exam. So go in later after class when we've forgotten everything and try again, because these kinds of questions will be on the quiz. They'll be on the exam. Oops. All right. So let's dive into synovial joints. When we talk about these freely moving joints, we need to have some special structures. Back up a moment here. We talked about how we have our ligaments on the outside, and we've got our cartilage on the inside to ensure that these kinds of joints can move and not cause problems, but also not move too far. That's what my capsules and my membranes do. When I talk about really major joints where I do a lot of movements, so for example, we're looking at the shoulder joint right now, we'll also see structures like bursa or tendon sheaths that are going to help when all these movements are happening for there to be less friction. So when I use the word bursa, I'm talking about a fluid-filled sac. So we have these little fluid-filled sacs that are in between tendons and a bone. When that bone moves, or in this case, it's kind of almost looks like it's rolling, that bursa will roll with it so that we're not rolling against this tendon and damaging it. So fluid-filled sacs in our synovial joints are called bursa, and then those tendon sheets that I mentioned, an extra layer of connective tissue so that my tendons don't get worn down with movement over time. When we talk about synovial joints, the bursa that it has, or the ligaments that it has, whatever its overall structure is going to give me a good idea of how many different directions it can move in. And remind me for a moment, when we talked about synovial joints, these were synarthroses, diarthroses, or amphiarthroses. What's synovial? Diarthroses, right? Okay, so every single one of my synovials, freely moving. But when we talk about what that freely moving looks like, it's going to be a little bit different based on the number of directions I can move in. So we're going to talk about synovial joints that are called synovial plane joints. When I talk about a synovial plane joint, I use a word called non-axial to describe its movement. When I talk about a non-axial joint, all it does is these bones slide past each other one way or the other, but we don't change any angles. There's no major movement. To make non-axial make a little more sense, let me show you a uniaxial joint. So a uniaxial joint is the kind of joint that you have at your elbow, for example, up and down, or the kind of joint that you have in your knee. When we talk about our movement words at a synovial joint, there's only one axis, or kind of one set of directions that these joints can move. So some of my joints are going to be uniaxial because of what's going on with the hinge joint. So I think of a hinge joint like a hinge on a door. So I've got one part of my joint, or one bone for my joint, the other bone for my joint inside. All it can do is go back and forth. That's going to lead me to be uniaxial. Or like we see here, we can see that movement only back and forth. The knee, the elbow, great examples of uniaxial, one set of directions. We can have some joints that are called biaxial, and biaxial joints can move kind of in two directions. So I like that they have the wrist joint here for us because we can all do this. Let's all be awkward together. Ready? Everyone raise a hand for me. I promise I won't make you commit to anything too crazy. Okay. The first axis we can move our hand is we can go forward and backwards. So we're moving our hand across one axis. This is my axis, forward and backwards. But the other way we can move our hand is from side to side. This is a completely different axis. We're going a different kind of direction. So when I have joints that kind of come together with kind of like a cup structure, that allows me to go one direction, and while I'm at it, another direction as well. So we're going to see this like we see here at the wrist joint. We'll see this down at the ankle joints. When I have this cup structure, I can move two ways. But again, the kind of joint you mostly think of when you're thinking about joints are what we call multi-axial joints. Multi-axial just means more than two. So 3 or more different axes where I can do movement. The way I get a joint that can move essentially whatever way I want it to move is it has to be a structure called a ball and socket. So ball and socket means that one bone kind of has a circular part at the top. In this case, we're potentially looking at the humerus, for example, the head of the humerus. And my other bone, my scapula, has an indentation for it. So when I'm thinking about the kind of axes that my shoulder joint can move on, I can do the whole backward and forward thing. That's one axis. I can do the up and down thing. But then what I can also do, that's going to be kind of hard for you all to see, I can rotate that joint in and out. So when I'm going in more than one direction, not just forward, backwards, not just up and down, when I can do anything, any way that I want to, I'm called multi-axial. So ball and socket joints, that's going to be places like your shoulder or your hip joint. Those joints can do whatever we want them to do because of the structure of their bones. But when we're thinking about non-axial, so let's come back to here. Non-axial means I can't go forward, backwards. I can't go side to side. I can't go in a circle. This kind of non-axial movement, that's what you're going to see in the little tiny bones in your wrist called the carpals. They just slide past each other. They don't bend forward and backwards or side to side. They just slide. So the carpals, they're just going to slide past each other. If you're sliding, no axis of movement, you're non-axial. Otherwise, you can go one way, you can go two ways, or you can go all the ways. So with that in mind, I'm now going to talk you through the specific kinds of synovial joints. Here's what I'm going to tell you about these specific synovial joints. I do not need you to memorize all of the examples of all of these different joints. Focus on the major ones. So for example, probably would be good for us to know about the humerus and the ulna, the elbow joint. That's probably important. Maybe a little less important for us to know about these intercarpal joints. So generally know where things are, really focus on the big ones. So first joint, perhaps not as exciting, the synovial plane joints. Ooh, step back here. When we talk about a synovial joint, what did we say that synovial joints had between the bones? They got the fluid, right? The fluid and then the cartilage. Here's a wink, wink, nudge, nudge. With synovial joints, sometimes we end up with these ones like we see here in the wrist that like basically don't move, but they have fluid-filled spaces between them. That's what makes them synovial. So synovial plane joints. This is a kind of joint that doesn't move forward and backwards, side to side. It's non-axial. It just slides back and forth. Synovial plane joints we find between the carpal bones, the ones in your wrist, between the tarsal bones, and there's a place where the back parts of your vertebrae connect with each other. So part of it hangs down and the other part reaches up. That's another place where we find these synovial plane joints. I want you to focus on in between the carpals, in between the tarsals. All these guys can do, they can slide, because that's the only way they can move. Synovial hinge joints, like the elbow, for example. Synovial hinge joints are uniaxial, because remember, you can go forward, you can go backwards, and that's it. One direction, uniaxial. So the elbow, really good example of this. The knee, really good example of this. I care less that you know about the ankle and the interphalangeal joints. Make sure we know that the elbow and the knee are my hinge joints. Then we have some joints that are called pivot joints. When I talk about a pivot joint, think about what you would do if you were pivoting. You're standing facing toward the front, and then you pivot. We're rotating around. So my one axis, if I'm a pivot joint, is the fact that I can turn in a circle. I can't bend forward, I can't bend backwards, but I can turn in a circle. I can pivot So I'm uniaxial, one direction that I can do movements. Best examples of this, the one I really want you to know, atlantoaxial joint. Atlantoaxial joint. And that probably sounds real crazy, and we may not know where that is. Let me help you decipher it. Atlanto means atlas. Atlas, as in cervical vertebra number 1. Axial, in this case, is referring to the axis, vertebra number 2. If you remember way back in the day when we were studying bones, the first vertebra was kind of a flat, open circle. And the second vertebra, the axis, had this point that came up inside that vertebra. That point, the dens, allows you to rotate your head side to side. The one axis that we can move that joint, where those two bones come together, that joint only goes around in a circle. Now, we have other joints that are in the skull that let us do the forward-backwards, but atlantoaxial, it's just the rotation of the skull. The next kind of joint is my first example of biaxial, meaning I can go in two different directions. So this is called a condylar joint. A condyle was a word that we used with bone markings. It means a round structure, a condyle. So when I talk about a condylar joint, I've got this round structure that basically has a cup on top of it. These two things are going to kind of rotate back and forward with each other. So good examples of the condylar joints, big long words here, metacarpophalangeal joints, metacarpals, phalanges, metacarpophalangeal knuckles. Knuckles can go forward, backwards. They can go side to side, moving your fingers. So the metacarpophalangeal joints, the knuckles, and the radiocarpal joint. That's the one we were doing before, remember? The radius and the carpal, radius and carpals, forward, backwards, side to side. So condylar joints, right here in the wrist, right here at the knuckles. Two directions, forward, backwards, side to side. Last set of synovial joints. Synovial saddle and synovial ball and socket. When you think about a saddle joint, it looks like a person sitting on the saddle of a horse. And when you sit on the saddle of the horse, there's two kind of ways you could fall off the horse. Way number 1, we're falling off on the side. Way number 2, we're falling backwards, or we're being bucked forwards. So when we think about a saddle joint, another example of a biaxial joint, forward, backwards, side to side. The one that I want you to know, really the best example that I want you to know, is called the carpometacarpal joint in the thumb. That's this knuckle, special part just on the thumb. The reason we care about this joint is because of this. This movement right here is called opposition. Humans have opposable thumbs. The only way we can do this is because of the carpometacarpal joint. So, carpometacarpal joint, your thumb can move forward, backwards, side to side, and it can do that cool opposition thing. That's a synovial saddle joint. And then the one that we talked about before, the freely moving one, ball and socket. This is my only kind of joint that can do whatever it wants. It's multi-axial. And we gotta know, 100% gotta know, the shoulder and the hip are ball and socket joints. So we just went nuts and talked about all the different kinds of joints. A quick summary that shows us how axial these different things are, or the ways that they move, this animation here. So a synovial plane joint, notice how these two bones never change their orientation to each other. We're not forward, backwards. We're just sliding across each other. Synovial plane. Synovial hinge. Remember I told you that's the elbow or the knee. These can only go one direction. Uniaxial, forward, backwards. Condylar joints. These were those knuckles or in the wrist. These ones go side to side, forward, backward. The pivot joint, which allows you to turn your head, that's uniaxial. Ball and socket, notice it's just doing its own thing, going wherever it wants to. And then that saddle joint, biaxial, forward, backwards, side to side. Here's the other thing I'll tell you about this exam. As much as you might feel awkward doing this on your video, I promise I'm not going to watch you if you hold up your wrist and you're like, okay, which way does my wrist move? Okay, I got forward, backwards, I got side to side. Okay, that's biaxial. Or if you're moving your thumb forward, backwards, side to side. I think I told you this with the muscles exam as well. You have your body when you're taking the exam, and I do not care if you're nodding your head and rotating your head, use it. So if it helps you when you're studying to say, the elbow is a hinge joint, uniaxial. You are allowed to touch and say those things out loud as you're studying to help you recall them when you take that exam. So there's my wink, wink, nudge, nudge for you. Before we start talking about specific movements, let me pop up a couple of questions in here. 2 questions. One about the types of joints and one about those axial words. I'll give us about 30 more seconds, see if we can wrap it up. All right, last call for that first question. 3, 2, 1. When we talked about our various kinds of synovial joints, all of these kinds of synovial joints we said were diarthrotic. They can all move a whole lot more than all my other kinds of joints. But when we're thinking about who is the movingest of them all, if you will, the one that can move the best is the one that can move in the most different directions. So my type of joint that is multi-axial is the ball and socket joint. That is the one that can do the most kinds of movements. Then I asked you to use those axial words, again with the names of our joints. So specifically, I asked you for uniaxial joints. When I talk about uniaxial, how many different directions can I go in? Yes, that one axis, right? So I can go forward or backwards, but that's it. When we're thinking about uniaxial joints, the first example we talked about were the hinge joints, like we have here in the elbow, like we have in the knee. The other example we talked about were those pivot joints, like we have up here in the skull. We can do one direction, and that direction is rotating. I'll mention with my other kinds of joints, which of these would be considered biaxial? Who's biaxial? Condylar and saddle, right? These are my biaxials. And remember that my plane joints, we technically call those non-axial. They still move, they slide past each other, but they don't do anything along an axis. When we talk about multiaxial, uniaxial, etc., we're talking about certain kinds of movements that we can do with the body. So there are 3 different groups of movements that synovial joints can do. Movement type number 1 is gliding. So gliding is a kind of movement that my synovial plane joints do. When bones just slide past each other, move back and forth, they're doing a kind of movement called gliding. We also have movements that are called angular movements. And angular movements is primarily what we were talking about. So we were doing forward, backwards, or we were doing up and down. Those were examples of angular movements. We also, though, have rotational movements. And when we talk about rotational movements, we're just rotating or we're turning. So as we get ready to talk about the different kinds of movements that the body can do, keep in mind, primarily the movements are either going to be angular or they're going to be rotational. Those are the 2 main movements. Gliding, that's what those 2 flat bones do when we are non-axial. Let's start by talking about angular movements. And when we do angular movements, think about this as the angle between 2 bones is changing. So the first set of terms, and I do want you to learn these in groups. The first set of terms is flexion and extension. When we do flexion, the angle between our bones decreases. So I've got my arm out here. When my arm is flat, I've got a big angle between my humerus and my radius and ulna. When I do flexion, now my angle is smaller. But again, what I put here in parentheses makes more sense to me. Flexion, bring them together. Yes, the angle gets smaller, we're bringing them together. Extension, the opposite, increasing the angle between them or moving them farther apart. Some of our joints, not the elbow, but some of our joints are actually able to extend past anatomical position. Good example of this is the wrist joint. So when I'm in anatomical position, my wrists are out flat, so I flex them toward my forearm, I extend them back to anatomical position, and then I hyperextend them, like if I'm holding something like this. The fact that it went back farther than the normal, that's hyperextension. So hyperextension beyond what's normal, flexion, bring them together, extension, pull them apart. All of these, one type of angular movement. I can also do these kinds of angular movements with the entire body. So you can do flexion and extension with your intervertebral joints going forward and backwards. We talked about the wrist, talked about it at the shoulder, and we can also do this at the knee. I will tell you, I'm not really going to test you on this for the joint section, but this does come up in muscle anatomy. Remember that flexion and extension at the knee joint was opposite. So when you kick your knee forward, that's doing extension. When you pull it backwards, you're doing flexion. It makes sense from our definition here, but for everybody else, flexion is forward, and extension is backwards. The knee is just the opposite of that. My next kind of angular movement is called abduction and adduction. Abduction is when we move a structure away from the middle of the body. I love to act this one out because it's just fun for me. I'm going to pretend that the aliens are abducting me. There goes my arms. Abduct, they start here. Here's the midline, they move away. Adduction is when we add them back down. So abduction, up, adduction, back down. You can actually do this with your fingers as well. The midline of your hand is your middle finger. So when we abduct our fingers, they're spread out. Adduct them back together. It's the same thing as what we're doing with our shoulders. We can also, at our ball and socket joints, do circumduction. In circumduction, we're making circles at that joint. So it's not going away from or toward the midline. It's going in a circular movement. Now we're talking about movements that are rotational movements, and the good news with rotational movements is that their name literally says they're rotational. So medial rotation and lateral rotation, when we move something toward the middle or away from the middle, but again, we're rotating, so not like I did with abduction away, but instead it would be if I make these bones rotate away or rotate toward. That's lateral rotation, medial rotation. This is abduction and adduction. So see how my elbow joint didn't move, it just rotated back and forth, whereas it moves here. We can do this with our entire body, rotate toward the middle or the back, and we can also do this with our head, rotating the head backwards and forwards. Then we have some groups of movements that we call special movements. For a lot of these, we could fit them into rotational or angular, but with these special movements, make sure you know which particular joints can do them, because that's what makes them special. Only particular joints can do them. So let's start with pronation and supination. Pronation and supination is something that we do kind of up here with the radius and the ulna. When I turn or I rotate my radius and my ulna, the palm of my hand either goes forward, pronation, or it rotates back up, supination. Hey, here's my silly way to remember that this is supination. Way back in the day, when Dr. Ahles was a little kid, we barely had TV. I'm not quite that old. But on TV, they had this ad where these people would just randomly show up to each other in the middle of a grocery store, and they go, "What's up?" And they put palms up. Supination, what's up? Pronation. I always like to say that my students are pros at looking cool. Meanwhile, I'm over here, "What's up?" So, supination up, pronation down. That's a special movement that just moves the palms of the hand. We can't do that anywhere else. Two movements that we can do just at the ankle joint. Plantar flexion, dorsiflexion. When we do plantar flexion, I did not wear the shoes for this today. Plantar flexion is when you go tiptoes. Gonna fall over. Plantar flexion, you plant your feet down, tiptoes. Dorsiflexion, we're rocking back on our heels. So dorsiflexion, we're moving the foot toward the back. Plantar flexion, we're moving it toward the ground. Tippy toes, rocking back on your heels. The other special joints that are movements that we can do at that ankle joint, aka the two ways to sprain your ankle. You can do inversion, roll that ankle in, or eversion, roll that ankle out. Either way, not ideal, but inversion, eversion, special to the ankle, along with plantar flexion and dorsiflexion, special ankle movements. Pronation, supination, these are special wrist movements that we see the palm moving. We can also do protraction and retraction. Primarily when I learned protraction and retraction, it was mostly with the jaw joint. So protraction is when you protrude your jaw, when you have an underbite, so your lower teeth stick out. Retraction is when you pull your jaw backwards, so you'd have an overbite. Protract and retract the jaw. You can also do this with the shoulder itself. So if I protract the shoulder, just send it forward, or retract it back. Forward and backwards, not the same as some of my angular movements, but forward and backwards, protraction, retraction. In addition to protraction, retraction, I can also do elevation and depression with the mandible. So when I elevate the mandible, it comes up. When I depress it, it drops down. Elevation and depression. Again, this is something that I can do with my shoulders. Remember that my shoulders were ball and socket joint, so anything goes. They can do protraction and retraction, elevation, depression. They can do it all. Then we've got that special movement because of our synovial saddle joint, opposition. Something only place we can do opposition is at that thumb joint where it connects to your palm. So opposition, special to my thumb. I'm going to suggest one more time. Remember that you have your body during the quizzes and the exams. If you want to do some elevation and depression while you're taking that exam, I don't care. If you want to do some flexion, extension, some abduction, I don't care. Do an interpretive dance if it helps you to remember these terms. So active learning as much as you can. This is a great thing to do actively. I want to move into talking with you about problems that we can have with our joints. So when we talk about problems with the joints, primarily this is going to be problems with the helping structures at the joints. So helping structure number one was our cartilage. If my cartilage is torn, I'm going to have some big problems. And as I get older, cartilage is naturally going to be broken down. So it's not uncommon to see a cartilage tear in an older person, but in a younger person with a cartilage tear, it's most likely due to either some kind of major accident or from something related to athletics. So the cartilage is normally strong in younger individuals and breaks down with aging. If I lose that cartilage, the first thing that I'm going to notice is that joint is going to become a lot more stiff. But as that cartilage continues to get broken down, as that inflammation continues, I might actually end up being so stiff that that joint is kind of hardened and it doesn't move well. So I need cartilage in my joints to do smooth movements. If I tear that cartilage, it's at least going to be stiff until it's healed, or it's going to stop doing those movements. Oh, apologies. The most common kind of tear would be tearing the meniscus. That's a really big cartilage that we have in the knee. So a meniscus tear, if you hear about an athlete that did that, that's the special cartilage on top of the tibia. And think about that. Your femur sits right on top of the tibia. If I tear that cartilage on top of the tibia where the femur sits, ouch. That's a lot of pain in that one place there. I can also have issues with some of those connective tissue structures that we had. So there's a condition called bursitis. Bursitis is inflammation of the bursa. So remember that a bursa is a fluid-filled sac that we have at various places inside our joints. If that, for some reason, that fluid-filled sac becomes inflamed, it starts to get swollen. Here's a very severe case here where you can actually see that bursa protruding from the knee. So think about this kind of as a fluid-filled, angry sac, not happy when we start trying to do some of our movements. Typically, this is going to be an overuse injury that's going to cause us to get bursitis. We can also have tendinitis as well. And tendinitis is going to be caused, again, by overuse. What happens in tendinitis is when you're using a muscle repeatedly, it's normal that some little tears occur in that muscle. But if you don't give that muscle time to repair those tears, we end up generating an inflammation reaction, tendinitis there. So tendinitis, we've used our tendons too much, tendon painful. Bursitis, too much movement, too much friction. My fluid-filled sac has expanded dramatically. When I talk about things like sprains or dislocations, these are both going to be issues with my ligaments that I see at my synovial joints. So a sprain occurs when a ligament has either been stretched out or actually been torn. So if you ever sprained your ankle, if we've just stretched it a little bit, we might see some small tears in that ligament. If we've stretched it really far compared to where it should be, it might completely tear. A quick note about ligaments, by the way, ligaments have really bad blood supply. So if I don't have good blood supply, it's really hard for me to heal. That's why a sprain hurts for so long, because I tore some of those proteins, but I'm not getting enough oxygen and nutrients to fix it very quickly. So sprains, we've stretched out those ligaments. And when we talk about dislocations, this is we've provided enough force to physically push the bones out of their socket. So they're no longer within their alignment at all. We obviously are going to want to try to get that bone back into its socket, but typically what happens with a dislocation is we're going to see things like sprains, where we tear our ligaments. We're going to see inflammation, where it's angry. We're not going to be able to use that joint. Over time, as we relocate things, those joints will heal themselves. I'll mention, because I don't have it here in my notes, when we talk about dislocations, dislocations are most likely to happen at joints that are highly mobile. So ball and socket joints, because they can move everywhere, dislocation possible. Things like we see here with the ankle or with the hip. The more mobile a joint is, the less stable it is. So joints that are really mobile are more likely for us to see these dislocations. The last kinds of things we're going to talk about with our joints are arthritis. And when we talk about arthritis, there are a lot of different kinds of arthritis. We do need to be familiar with what makes them different. So the most common kind of arthritis is called osteoarthritis. Osteoarthritis is something that unfortunately pretty much all of us will have some symptoms of with aging. That's because in osteoarthritis, that cartilage that kept our bones separate from one another has really started to soften and deteriorate. Remember, that was normal with aging. Cartilage starts to go down. So osteoarthritis is a problem caused by that cartilage going down. So ways that we would know that a patient has osteoarthritis: you might hear a crunching sound when they're moving that joint because the bones are rubbing against each other. We can develop these things called bone spurs, which are little bone growths on places where normally we would have had cartilage. There's no cartilage there. I'll grow some new bone tissue. When we look inside the knee, notice here's a normal articular cartilage. With aging, that cartilage has worn down, and we're starting to see these little bony growths around that joint or inside that joint developing because of the wear and tear as these bones are moving across each other. So osteoarthritis, like I mentioned, this just comes from using your joints regularly. It develops slowly. We don't really have a way to reverse this. Maybe one day we'll come up with a way to build new cartilage in our joints. Until then, this osteoarthritis thing is the most common kind of arthritis. Yeah, question? Yeah. Yeah, so the question is, can this develop in young people? And the answer is yes. So mentioning a friend that was a competitive athlete, this is formed because of wear and tear. So if you're a competitive athlete, if you're someone that has repeated wear and tear on your joints, it is possible, yes, this could develop in younger people, absolutely. The next kind of arthritis is actually an immune system problem called rheumatoid arthritis. Rheumatoid arthritis is when the immune system starts to attack your synovial joints. So the leukocytes, the white blood cells, split out their inflammatory chemicals. Those chemicals being spit out into this joint cause the body to have an inflammation reaction, which inflammation is a way we deal with intruders. Shouldn't be something we do against ourselves. So as this inflammation reaction occurs at a synovial joint, Just like we saw with osteoarthritis, the cartilage gets broken down, and we replace that cartilage with scar tissue called pannus. So now instead of having cartilage at the end of our bones, we've got this scar tissue that ossifies, turns into bone, and we lose the ability to use those joints. So osteoarthritis, you might see an x-ray or something that shows, notice how these fingers are very much out of their normal movement patterns or normal locations. Because the cartilage inside these joints has turned into pannus and then has turned into bone. So when we talk about rheumatoid arthritis, because this is an autoimmune problem, we can actually suppress the immune system or give anti-inflammatory medications, because it's that inflammation, it's the joint getting angry that leads us to develop this bone tissue inside the joint. So rheumatoid arthritis, immune system problem. Osteoarthritis, aging problem. One other kind of arthritis for you to know is called gouty arthritis. And with gouty arthritis, we have a buildup of what's called uric acid inside your joints. So uric acid is a waste product that normally you get rid of in your urine. Your kidneys deal with it for you. But if we have too much of it in the bloodstream, it'll actually get inside of your synovial joints, solidify into these structures that basically kind of turn into needles, these long, thin uric acid crystals. And check this out, when I put uric acid in the joints, the immune system says, you are not supposed to be here. And so just like we saw with our rheumatoid arthritis, now the immune system starts attacking the joints. It's not attacking the joints themselves, it is attacking the crystals, but this still leads to pain and inflammation. You'll see those deposits that are present that then cause swelling around the site where we have an immune reaction going on. Just like we saw with rheumatoid arthritis, we're going to try to treat that with anti-inflammatories. And uric acid can get high if you don't drink enough water, so you can drink a little more water to try to offset that. With that, we are done with joints. Really fast, I want to give you, oh, I guess I don't have it, never mind. Okay, here's a wink, wink, nudge, nudge practice question that I want you to do at home. I want you to make sure we know which kinds of arthritis are caused by the immune system, which kinds of arthritis lead to building new bones in our joints, and which ones are problems with cartilage. If you are on my magic list, come see me. Otherwise, I hope to see all of you on Wednesday. Good luck with exam number 5.
Hey, Dr. Ahles, I have one question. On the quiz, it was asked what's bigger, like in order from smallest to largest. It was fascicles, individual muscle cells, and muscle fibers. Do you know what I'm talking about?
I don't know for sure about this specific question.